Okay. So, I don't think it needs to be said, but I'm going to say it anyway. Mazel tov. No. Um, I think we're all here because we recognize that health is more than doctors and nurses. It's more than hospitals and clinics. But many of us are also here because we are doctors or nurses, and we do work in hospitals and clinics. We're here because every day that we do patient care, we hear from our patients how the social determinants of health impact their lives in both positive and negative ways. And that's what I'm going to do in my talk, highlight the role of social determinants of health and upstream thinking within the healthcare system. And I'm going to do it in 3 ways. First, I'm going to talk about the current state of our healthcare system from a social determinants perspective. Then talk about how it's changing and where there's opportunity for us to do the third, and that's to institutionalize upstream thinking into the way we deliver healthcare services. But before I dig into the substance, I want to start with a story. I think stories are important, especially for those of us who are on the front lines, because they ground us to the work and to the conversations that we have today in rooms like this one. And I'm going to share a story from right here in Ottawa. Before I moved to Toronto and started working at St. Michael's Hospital in the Department of Family Medicine, I was a physician here in my first year of practice. It's a story of someone I'm going to call Jane for the purposes of today, but the rest of the details are true. Jane was a patient in her early 60s who looked older than her stated age. We usually saw each other every 3 or 4 months ago, and typically we would check in on her diabetes and her sugar control. And Jane was an excellent patient. If her sugars weren't right on target, they were very close to where they needed to be. But I remember one particular visit when we saw each other, and her sugars were completely out of control. They were reaching high highs I had not seen for her before, and low lows that for many people trigger not just nausea, vomiting, unsteadiness, but in severe cases, even coma. Now, thankfully for Jane, she had been spared from some of the more severe consequences of her out-of-control sugar, but not for all of them. So we started to have a conversation to see if we could figure out what was behind her out-of-control measurements. Had she changed her diet in any way that might have affected her sugars? No. Was she adjusting her insulin? No. Was she sick in any way that might have led to this unusual pattern? No. So we continued the conversation until Jane told me that she had had an unexpected expense in the past month. Now, for many of us, something like a lost bus pass or a minor house repair, it's not a big deal. But for Jane, it was. And that's because Jane had a very significant mobility issue. She was disabled, and she relied on social assistance to make ends meet. On a good month, she could make her check stretch from the first day of the month to the last. But the month that we saw each other was not a good one. She had an unexpected expense and it left her short. She had to choose between paying for rent on one hand and food on the other. It's no surprise she chose the roof over her head. And the money she did have for food, she stretched by buying cheap, highly processed, and easily available carbohydrates and cut down her meals to sometimes as little as only 1 or 2 meals a day. It was no wonder that her sugars were so out of control. But what was even more surprising to me is that she felt too socially isolated to go visit a food bank, or even too ashamed to tell me at the beginning of the visit why her sugars were so out of control. Now, I was sitting there in front of her as a newly minted family doctor, thinking about all the years of school that I had gone through, and thinking about what I was told to tell her, and that was to lecture her about the importance of exercise and eating well. It was obviously no surprise, the least helpful thing I could have done for her that day. And I think that's pretty emblematic of where our healthcare system is when it comes to social determinants of health. When Tommy Douglas first envisioned Medicare, he envisioned it in 2 stages. The first was to remove the financial barrier that many Canadians face to accessing healthcare. But the second was to fundamentally reorganize our healthcare system. So our organizing units weren't just hospitals, they were units of public health, GP offices, and communities. Now, it's no surprise to everyone, we have For not everybody, but for many people, we've done the first stage. We've removed the financial barrier. But we have done very little to move the needle on the second, and that's to reorganize the healthcare system. And the longer we wait to do this, the more urgent that need and that challenge becomes. The ways that we are getting sick are changing. We're getting fewer and fewer acute conditions and more chronic diseases, things like heart disease, diabetes, and cancer. But the good thing about these changing pattern of diseases and the conversations that they're forcing is that these conversations are starting to bubble up in all sorts of different ways. Right now, there are a number of provincial elections going on, and healthcare is being discussed in them. In the federal election that we had in the fall, all the parties were talking about things like prescription drug prices, the need to invest in home care, and community mental health services. I think we're lucky we ended up with a minister of health who fundamentally understands the social determinants of health. I think that's why she's going to be speaking to us later today at this meeting. But we're also beginning to see a change in tone from our medical leadership. You heard Dr. Forbes speak this morning about the fantastic work that the Canadian Medical Association did a few years ago on social determinants. More recently, the College of Family Physicians released this Best Advice Guide on Social Determinants of Health, which gives some very practical recommendations on how to integrate action on these factors into your day-to-day primary care practice. And I saw a bunch of copies floating around outside the hall, so if you are in healthcare, please do take one home with you. But I also want to give credit where credit is due. I'm a doctor, I'm speaking from a doctor's perspective, and my profession is relatively new to this conversation. But nurses and social workers, nursing organizations and social worker organizations have been having this conversation and beating this drum for a very long time, and they deserve much of the credit for getting us to where we are today. Which leads me to the third thing I want to talk about, and that's to take this conversation that's happening now and use it as an opportunity to push upstream, not just to talk about chronic diseases and community health, but to talk about institutionalizing upstream and social determinants of health thinking into our healthcare system. I'm going to share a few examples that I know best from where I work at St. Mike's in the Department of Family Medicine that both deal with front-end services, the things that patients see when they interact with the healthcare system, but also a few back-end examples of how we plan and operationalize the services that we do to make sure they have a social determinants lens. So the first example I'm going to share is an income security health program that we started a few years ago under the leadership of Gary Block. Gary's sitting right there. Gary, raise your hand, please. Gary deserves a huge amount of credit for getting this off of the ground. Through this program, we've brought 2 income security health promoters into our clinic that are co-located with the rest of us, doctors, nurses, social workers. And our staff can refer patients living at or below the low-income cutoff or the poverty line to see them. The health promoters will meet with them to help them navigate the incredibly complex web of social assistance programs we have, to make sure they're maximizing their benefits, maximizing their income, but they also help them with things like debt management and financial literacy. Andrew Pinto is another colleague of ours at St. Michael's who's really driving a lot of the research behind this, and he's leading a randomized control trial to help us understand what the patient impact of this program is. Since then, we've also launched a children's literacy program called Reach Out and Read. When a family brings in their child or their toddler for a well baby or well child check, one of our nurses will meet with the family, give them an age-appropriate book, talk to them about the importance of literacy and reading at home, give them the book to take home, but also talk to them about their local public library branch and the importance of building a culture of literacy. This is new to us, but it's a program that's built on the success of the Department of Pediatrics at Boston University, who's done exhaustive research to validate the outcomes. And finally, we've also launched a health justice or legal aid program where, much like our income security program, we've brought someone, in this case a lawyer, right into our clinic who sits with the rest of us. This is Joanna McDonald. She's the lawyer we're very lucky to have as part of our team. Just 2 months ago, I had a young family see me with their young daughter, telling me about some of the respiratory symptoms she was experiencing, but also about mold that they had found in their subsidized housing. Now, thankfully, I knew about this program, I knew about Joanna, and I was able to connect the family and Joanna. Because she was a lawyer, she was able to exercise the force of the law to make sure that the mold got cleaned up much faster than either I could have or the family could have done on their own. That's health justice. But we're also taking some time to do some back-end work and to really understand the data and the evidence. This is a health equity data collection that we're involved in with a number of other hospitals and Toronto Public Health to try and understand more information about our patients than just what's on their health card. We're systematically asking our patients questions about their income, their housing status, their ethnicity, and their language, so that when we continue to roll out and when we continue to iterate and improve some of the programs that I'm talking about, we make sure that they're tailored to our very specific patient population. We also wanted to make sure, and we want to continue to make sure, that the work we're doing is not perceived or is not done on the periphery or on the edges of primary health care. The work we're doing is important because it should influence the way we operate day to day as a family health team and as a primary care unit. And to that end, as a core part of our strategic plan, we integrated advancing systems of care for disadvantaged patients, including impacting their social determinants of health, into the way that we do business. Now, I'm very proud to be part of this team. It's the reason why I'm up here and speaking to everyone today. But I also want to acknowledge that if these programs are all we do for our patients, then I think ultimately we have still failed them. Part of the benefit of these services is to improve patient health outcomes within the healthcare system. But I think part of their benefit is to very clearly and very concretely show how health is linked to all of these different social and economic factors. It means that when we make the case, whether it's to our own patients or to the public, or most importantly, I think, to policymakers, that if we're investing in these services, if we're studying these services, if we're taking them seriously within what we traditionally think of health as healthcare delivery, then we should do the exact same thing when we think about broader social and economic policy. And many of us as frontline healthcare providers are using these programs and our upstream attitude as a bridge to talk about broader public policy reform. And I'm going to share just a few quick examples. A few years ago, many health providers, some in this room, were involved with other public sector partners in a campaign to raise minimum wage. We held press conferences, we wrote op-eds, using both stories and evidence to clearly show how living and earning a poverty wage leads to poor health outcomes. Right now, many of us are involved in the Decent Work and Health Network. It's in collaboration with the Workers' Action Centre in Toronto, working to lobby the Ontario government to change its employment legislation to make things like paid sick days a mandatory part of employment contracts, but also to get rid of unnecessary and burdensome sick notes and make it easier for workers to unionize so they can fight for the extended healthcare benefits that our healthcare system does not include. You can go to the quick plug 15 in Fairness website, sign up for the campaign, get on our list so we can bother you with emails. And finally, many of us are also involved in coming up with ways and advocating for novel ideas to change the way we deliver social assistance. You're going to hear more about the idea of a basic income. It's already generating a lot of buzz, so I'm not going to spend much more time on that. So I started my comments with my story, a doctor's story about a patient, and now that I'm at the end, I thought it was only appropriate that I turn the tables and I share a patient or a worker's story or speech to their doctors. This is a poem that a 20th century German playwright and poet wrote, Labrecque, and I'm not going to read it. I'm going to leave it on the screen and let everyone read it for themselves. So I'm just one of many, many other people who are doing this work. So I do want to acknowledge some people who have really influenced my thinking on this and have also done a really important work on this area. Gary Block, Rithika Gold, Daniel Martin, Ryan Miley, and Andrew Pinto. If you have any questions, please do reach out to me. If we don't have time to talk about them today, you can send me a tweet on Twitter or send me an email. Thanks, everyone.